Good afternoon, everyone. Welcome to the MDH Monthly Education Series. As we all know, February is Heart Health Month, and in the spirit of Heart Health Month, we are excited to bring you an update of the state of cardiovascular health in Minnesota by our own cardiovascular health supervisor, James Peacock. And then you will hear from the program manager from the Center for Resuscitation Medicine at the University of Minnesota, Kim Harkins, about this center and the history of the center, and the first responder AED initiative that we are currently working on around the state. Before we get started, there's a couple of housekeeping items. This webinar is part of the MDH Stroke Monthly Education Series. Stay tuned for your email for a different educational opportunity each month. This webinar is being recorded, and you can access all previously recorded webinars on our MDH YouTube playlist. Your lines have been muted upon entry. Please ask any questions by typing them in the chat throughout the presentation, and/or hold them until the end of the presentation, and we have saved some time for Q&A. If we don't get to all your questions today, however, we will address them in the follow-up email. You can also feel free to reach out to the team here at any time. Just a couple of quick announcements. We have, please join us next month on March 15th as we celebrate the 2022 EMS Quality Improvement Award winners. We will have a brief presentation from each awardee about their project and their results. Also, please continue to notify the team at health.stroke@state.mn.us of any program contact changes. And lastly, the 4.0 designation documents are available on the website. The objectives for today are: upon completion of this webinar, learners should be able to describe the benefits of having an AED in police cars, explain why current AED models are being replaced, and list 3 ways to improve the system of care for cardiac arrest patients. And now I turn it over to my colleague, Jim Peacock.
Well, thank you, Catherine, for that introduction, and thank you to everyone joining us for this month's Stroke Education webinar. As Catherine mentioned, we're squarely in the middle of American Heart Month. We thought today would be a good time to talk about current heart disease and stroke statistics for Minnesota, especially as they relate to the ongoing COVID-19 pandemic. There's a lot of information about how COVID-19 is impacting us all: new or worsening chronic conditions, workforce challenges reducing access to blood pressure, cholesterol, and diabetes management services, overburdened facilities like your own, and initial concerns by the public to seek appropriate emergency care when experiencing the signs and symptoms of a stroke or a heart attack. The good news is that overall, we've seen very little change in deaths due to heart disease and stroke in Minnesota during the first 2 years of the pandemic. This is not true of all states. And as a reminder, heart disease is the second leading cause of death in our state, and we have the notoriety of having the lowest heart disease in the country. And this has been true since at least 1999. In 2021, our death rate was about 29% lower than the US average. In 2021, stroke was again the 5th leading cause of death. And while Minnesota's death rate is 16% lower than the US overall, we don't do quite as well as we do with heart disease. We're ranked 14th amongst the states and DC with the lowest stroke death rate. For both of these conditions, though, these low death rates really hide striking disparities. For heart disease, young and middle-aged American Indian and Black Minnesotans are dying at rates 2 to 4 times higher than the state average. And for stroke, we see persistently higher death rates across most age groups for our American Indian, Asian, and Black neighbors. Next slide, please. So that was talking about deaths. When it comes to hospitalizations, we see a diverging picture. In that first year of the pandemic, we saw huge drops in the number of hospitalizations for heart disease, down 14%, and stroke, down 11%. These numbers really reinforced the anecdotal news we heard about emergency departments empty of patients with chest pain or stroke symptoms in the early months of the pandemic. In fact, the only group which saw an increase in hospitalizations during 2020 were young adults with stroke. And as I understand it, this has been a topic of discussion for many of you for years, how stroke patients are trending younger at your facilities. We at MDH are awaiting the 2021 hospitalization data to see if trends have returned to something that resembles that pre-pandemic normal. So I should highlight that what I just shared now, these are just summaries of data that we published at MDH through our cardiovascular health indicators dashboard. Catherine's going to drop the link on the page into the chat, or you can simply search MDH CVH dashboard in Google. You're going to find much more detail than what I shared just now, and many other indicators are presented on this page with trends and disparities highlighted. There are some high-level bullets, there are charts and tables that you can use for your own presentations or sharing amongst your team. Next slide. So I'm going to transition now to something that's a bit deeper look into the data and something that's not on the dashboard. This is a complicated slide, but I'll walk you through it. You may wonder about that different picture we see with heart disease and stroke deaths not changing very much, but hospitalizations going way down in 2020. This complicated chart here shows the location of death for patients that experienced heart disease, stroke, or any other cardiovascular condition as their cause of death. By month, starting with January 2020 on the left and ending at November 2021 on the right. Each one of these colored bars that you can't see very well compares the location of the person's death in that month with the average for the 3 years prior to the pandemic, so the years 2017 through 2019. That green line that you see below the center of the chart going from left to right is showing the trend for in-hospital deaths. And for the first 2 years of the pandemic, fewer people died in hospital from cardiovascular conditions than during that pre-pandemic period. And while it varied from month to month, often related to hospital capacity with the number of COVID patients in the facility, but on average, it was down about 10% for that 2-year period starting in March of 2020. Contrast that with the blue line that's above the center of the chart, which shows the trend of deaths occurring at home. Again, we see some variation, but consistently over the first 2 years of the pandemic, we see many more people dying at home from cardiovascular conditions than is typical. And over that entire period, these deaths at home are up by about 20%. This trend is more pronounced for heart disease deaths than it is for stroke, but this does explain some of this dichotomy we see in very little change in overall deaths versus big declines in hospitalizations. And next slide. So finally, I want to talk a bit about sudden cardiac arrest. We don't do a good job documenting and counting cardiac arrest deaths in our death data. And that's not something that's specific to Minnesota. This is true nationally. And there's due to a lot of different reasons. One important one is that many people experiencing sudden cardiac arrest will be found unresponsive. They may die in their sleep or while alone. And these deaths are often, not always, but often in individuals with existing known coronary disease. And those deaths are frequently attributed to STEMI heart attacks, one of the most common initiators of cardiac arrest. These deaths then are classified with STEMI, called the underlying cause of death. If we approach looking at sudden cardiac arrest in a different way, and we look at sudden cardiac arrest and ventricular fibrillation as a contributing cause of death, we see that for the first 30 months of the pandemic in Minnesota, that cardiac arrest was a contributing cause at least 10% more often for 23 out of those first 30 months of the pandemic. And for 10 of those months, fully 1/3 of that 30-month timeframe, cardiac arrest contributed to deaths 35% more often than it did in the pre-pandemic period. I'm sharing this with you to show that while overall deaths due to heart disease and stroke didn't change much, where and how people are dying has changed significantly. I also wanted to share with you an amazing story published by our friends at mHealth Fairview as part of Heart Month. This story highlights the importance of early recognition, accessing 911, providing CPR, receiving innovative critical hospital care, followed by robust cardiac rehabilitation to get a patient experiencing cardiac arrest back to what he loves doing. Catherine is again going to drop the link in the chat. And with that, I'm really happy to turn the presentation over to Kim Harkins, who works closely with the team who saved this patient's life. Kim, the floor is yours.
Thanks, Jim. Well, I appreciate the opportunity to be here, and thanks to Catherine for inviting me to talk a little bit about our program and then talk about the AED project that we have started here in Minnesota. Next slide. So just a little bit of a history of the Center for Resuscitation Medicine. We're actually a program within the cardiovascular division at the Department of Medicine in the medical school of the university. And so we started way back in 2010. We had a grant from Medtronic Philanthropy, really focusing on out-of-hospital cardiac arrest and how we could make improvements across the state to improve outcomes. And so a lot of our early work really kind of focused around the chain of survival. So working on improving bystander CPR, trying to get a more robust AED registry out there. We worked with some legislation with American Heart Association and also working with EMS to try to think about better ways to improve outcomes. And a lot of the work we did back then was with the implementation of CARES. CARES is the Cardiac Arrest Registry to Enhance Survival. And it is a cardiac arrest registry database that is, we provided on a state level, but participation comes from EMS. And the uniqueness of CARES is that it actually connects out of hospital cardiac arrest with the hospital outcomes, so that EMS is able to benchmark and see when they make changes in their care, how that improves outcomes. So it becomes a tool for both healthcare centers as well as EMS. We also, through the years, have worked on some clinical trials, including ACCESS, which was taking out of hospital cardiac arrest patients directly to the cath lab. We found that in Minnesota, we were already doing that so much that it was not very long lived. And then in 2018, we received a grant to take what Jim was describing, the ECMO work that was happening in the cath lab at mHealth Fairview University Hospital, and turn it into a more mobile program. And so that's when we established the Minnesota Mobile ECMO Consortium, and really it's a team that goes out to other facilities to assist with out-of-hospital cardiac arrest ECMO. We did a clinical trial on ECMO, the ARREST trial, which was actually stopped early because they were finding survivors lean so heavily toward the ECMO side versus standard of care. And then just this last year, we received a grant for the Minnesota AED project, which is the bulk of what I'm going to talk about today. Next slide. So this just goes back to our early beginnings. Like I said, we did a lot of work on bystander CPR with the CARES data. We saw that, you know, surprisingly, Minnesota had lower rates of bystander CPR. So we worked with the Department of Health and American Heart Association to make a program that had started at Alina called Heart Safe Community Designation, to make that a statewide program. So it would help communities encourage bystander CPR and AED placement. We worked with schools on CPR. We also had other activities working with dispatchers, EMS. We ran several academies. We used the data to push back out information and to help kind of guide the research around cardiac arrest work. Next slide. So this just gives you a little bit of a snapshot of CARES. This was in 2021. And so you can see here, you know, we look at the total number of cases, and we can actually look at that number that Jim was talking about, where you see that 78% that occurred in homes. That's actually quite a bit higher than we've ever seen before. So we also noted that same data point, that we were having more cardiac arrests happening at home during the pandemic. You know, we can compare in parentheses, you see that's the national data. And so right now, almost half of the United States is doing CARES data entry. Just recently got some significant legislative support. So we anticipate that the entire country will be doing it very soon. The nice thing about that is we can compare ourselves to like-sized communities. We can look at other states, as well as those national numbers, to make determinations of where we want to make improvements. In many ways, you can see Minnesota is doing very well. But, you know, when we look at this data, we can even look at the fact that the VFVT shockable rate, you know, was 21%, which is fairly high. So when you look at that, those number of patients really should be our most survivable, which is why we started pushing that ECMO program. One of the things that was notable in Minnesota during the pandemic is because we were able to use ECMO on some of these out-of-hospital cardiac arrest rates in the metro area, our overall survival from cardiac arrest did not change much, which is not true across the rest of the country. Most saw very significant differences in their outcomes from sudden cardiac arrest. Next slide. So as we talk about the AED project, we actually used CARES data, and this is from a few years ago, but we actually looked at this and said, okay, so who started CPR? And we found that we had a big difference in Minnesota compared to national, that by and large, it was our first responders that were starting CPR, and likely the first people to have an opportunity to put an AED on. We use this data to actually talk to the funder and say, this is why we think we need to equip our first responders or our law enforcement, who are often the first people there, with updated or newer technology. Next slide. So the Helmsley Charitable Trust are the ones that funded this. They've done a lot of good work across rural communities throughout Minnesota and the upper Midwest. But you can see here, they also have kind of a global impact and work on a variety of different areas. Rural healthcare is primarily the work they're doing in the upper Midwest. Next slide. This number is a little bit old. The contribution is quite a bit more since they have done this AED grant now throughout all of these states. They were also responsible for Lucas devices in all of EMS, as well as transmittable 12 leads in rural Minnesota. They have sponsored several other projects throughout Minnesota at Centricare, at the university, through the ECMO program, and a few others. So they really have had an impact on our state in rural healthcare. Next slide. So this is their first responder grant that was started, and you can see that they started in all the other states prior to Minnesota. You'll notice that little odd state sitting off there. The trustee from South Dakota lives in Nevada, so he is also providing this grant to Nevada. So I guess they are kind of a, you know, an addition to the upper Midwest. You'll notice that in all the other states, they distributed 10,000, almost 11,000 AEDs. In Minnesota alone, we were awarded 8,300 AEDs. So we are by far one of the largest distributions across the upper Midwest. I think the key thing with this type of, I guess the best way to say it is purchasing power. They were able to work with the company that's providing the AED and really pull together a package that is pretty amazing. These AEDs come with an 8-year warranty, and during that warranty life, they are able to get electrodes anytime the device is used on a patient. They also are given, it's almost a 50% discount on the electrodes and the batteries during that 8-year warranty life. And every case or every use of the AED is annotated and they get a review back. So it's really an amazing kind of package that comes with this unit going to law enforcement. Next slide. So, you know, our thought process behind it, of course, is that we know AEDs should be applied within the first 3 to 5 minutes. And honestly, you know, we know that EMS has an average of 8 to 10 minutes, which is still pretty phenomenal in some of our rural areas. But we do know that when they call 911, often that first person to arrive is a law enforcement officer. So ensuring that they were properly equipped was really the impetus behind this grant. Next slide. So when we looked at this, it's actually a 3-year grant, 8,300 AEDs, and the grant itself was for almost 19 million, really just to purchase those units, which is the bulk of the dollars, but also kind of supporting the project, data collection, since we are getting those code stat cases back. We are giving feedback to the agencies, helping them with training, and evaluating their program. The AEDs themselves are going to city law enforcement agencies, county sheriffs, state law enforcement, DNR, tribal law enforcement, park law enforcement, campuses, and state emergency management. So it's really all encompassing for anyone that would ever be responding to a 911 call. Next slide. We decided to go with proven success. When the Lucas was distributed to EMS several years ago, they followed the EMS regions. And so that's pretty much what we've been doing as well. We've also been utilizing those EMS regional directors because often through the EMS agencies they work with, they have contact with those law enforcement officers for training or even just participating in some of the events that they do. So we're utilizing them to help with getting trainers out there and having the devices available. We did an early survey prior to the grant, and then we continue to do follow-up surveys to find out how they feel this is being implemented, if it's working for their team, if they have any questions about it. In our initial survey, we actually were, we knew that Minnesota had a pretty good AED distribution with law enforcement, but we were actually surprised to find some pretty big gaps throughout the state. Most of our tribal agencies did not have AEDs, the law enforcement officers. We also found that there were some larger metropolitan areas that did not carry them. They had at one point, but when they aged out, they were not be able to replace them. And so we found gaps kind of across the state. We found some county sheriffs where they only had so many devices throughout their fleet, not necessarily in every vehicle. So we really saw this as a great opportunity to build up some of those gaps and hopefully have better coverage throughout the state. Next slide. This just gives you a snapshot of our estimate around the state for the number of AEDs that we thought we would need. You can see here in the upper northeast part of the state, which was our first distribution, you can see how the distribution kind of laid out across the region. We also found that with providing these to State Patrol and the DNR, a lot of those large open gaps were even filled just because of the roaming vehicles and those and officers. Next slide. So as I mentioned, police departments, sheriff, tribal agencies, campus, to date, we have distributed 4,272 AEDs. And this is just with the Northeast, Northwest, Central, and Metro. We still kind of have that western side of the state and then the complete southern side of the state to finish. And we are just past, well, actually of today, we just hit the 1 year mark. So we accomplished quite a bit in the first year. Next slide. Now, I mentioned the connected benefit of these devices. On the one side there, you will see what a code stat report looks like. So anytime the agency goes or the device is used, once it connects to Wi-Fi, because these are Wi-Fi enabled devices, which could be from the hotspot in their vehicle, it could be when they bring it back to the station, it automatically uploads the case, and that actually triggers the shipping of their pads. So most agencies say within 24 to 48 hours, they actually receive those new electrodes for their device. But then within about 24 hours, they get this report where you can see up in the top there, the green dials. That's showing their compression rate, their CPR ratio. So it's really giving them a lot of feedback on the case as far as how things went. They can see where shocks were delivered. And so it becomes a really good QA tool for them to understand how well they're doing CPR. Now, honestly, most people are a little worried when they know they're going to get feedback on every case. But by and large, when we get our quarterly reports about how CPR is being done, everybody's really doing a very good job at CPR, which is no surprise. It's just good to see that kind of in the data. The other thing is that these devices, when they're in a Wi-Fi connected area, whether that might even be their vehicles, it can actually let incoming EMS know that the AED has been applied and what that rhythm is. So incoming EMS has a better idea of what they're going to be coming into. Next slide. So this shows that quarterly report, and you can see that at this point we'd had about 50 some cases here in Minnesota just in the first few months. And you can see that, by and large, their CPR ratio is very well, compression rate, their compressions per minute, they're doing very well. And so this just gives us some feedback to kind of show the entire state how they're doing, as well as each agency can use this for their training tools. Next slide. So as of, I think it was last month, we were at 64 cases. We've already had 4 known first responder saves, which means they had a pulse back, person was starting to wake up on scene. So we've actually been working with some of these agencies just to highlight the really important work that law enforcement does. Next slide. So another piece of this that we decided to do a little bit differently than the other slides or other states, is that we knew that many of these agencies would have devices that were older and needed to be destroyed. That's understandable. However, we knew that a lot of agencies would have devices that were relatively new. And so we kind of put together this opportunity to redistribute those AEDs. So we asked agencies if they would like to use them within their own organization or city, maybe putting one in their physical station, providing them to fire, other city agencies. They could also choose to donate them to their community if they already had something in place and they wanted to do that. The other option was they could donate them to our program, to the Center for Resuscitation Medicine, to kind of repackage, update if needed, and then redistribute through a grant process. And then, of course, there's an FDA site that they could check, and if they needed to be disposed, Stryker, who is providing the devices, volunteered to have all devices shipped to them, and they would dispose them appropriately. Now, we did get some money through the Lillahai Family Foundation and the University of Minnesota Foundation to help us with this redistribution, whether it was buying new electrodes, helping agencies with maybe a cabinet or a hanger to get it in their organization. Next slide. So this is our recycle reuse program. We invite people to fill out the application. And I use that word loosely. We're not turning a lot of people away. Our biggest goal is to have them in public locations. We want to make sure that they're getting used and that we hope they're not getting used. I guess I should say that differently. We want to make sure they're in a place where if there is a need for use, they can serve the largest population. So we've had churches, we've had businesses, we've had communities out in rural Minnesota where they have a community group because they're very rural or off on a lake. And so those are lots of the different places that we've already had and placed AEDs in. Another place that has come to us has been some of the fire departments because they may have budgeting issues where they can't replace them, and this gives them an opportunity to do that. Next slide. So our biggest donation was the State Patrol. The State Patrol gave us almost 700 AEDs to put back out there. We've also had some counties and cities start to donate. We check them, update them, and then we try to make sure they have at least a year on the electrodes and battery. Otherwise, we go ahead and replace them. Next slide. Now, one of the things we're asking is when they put them out in the community to use PulsePoint. PulsePoint is an app. The AED locator is a free portion of their app. And so it's something you can download on your phone and see where all the AEDs are in your community. And so we asked them to go ahead and upload their AED to PulsePoint just so we can get a better picture of Minnesota and where there's gaps throughout the state. Next slide. So you can see this is just an example of PulsePoint. You can see that it shows a picture of the AED. In any community, you can see all these gray and yellow AEDs. Gray just means they need to be authorized or they need a picture. The nice thing about this, about PulsePoint, is that it does also work well in businesses, because if you enter the business hours, or it uses Google Business to determine hours that the business is closed, and then it will not show that AED is available. So it offers that opportunity as well. And it does also, if the AED is placed at an address and it's not quite located, you can actually shift it over to get it right in the accurate position in your building. Next slide. So there's just another example where you can see it positions where it has the opportunity to put that in text as well. And then there's also a picture of where that location is. Next slide. So we have noticed that we've had some significant growth with AEDs throughout Minnesota. You can see that quite a few communities are utilizing this to track where their AEDs are. And so we hope with this grant, we'll see continued growth. We don't know if it's just because of our pushing it out or if people are just more aware of the app and using it. Next slide. So what we have learned through improving, doing the AED grant, the ECMO grant, and trying to improve systems of care is that we know we still need to do CPR and AED training. Our bystander CPR rate continues to fluctuate, and we know we could increase that. We've learned that there was gaps of AEDs in law enforcement and first responders, and we're really trying to address that. We know that there's lots of large areas with few public access AEDs, especially in areas with long response times. And we hope that being able to grant these back up, we can help fix that. And then, of course, we know that improving cardiac arrest outcomes needs both local engagement for the CPR and the AED placement, but also healthcare advancement, understanding what opportunities exist and how we can get them to the patients faster. Next slide. We have done some improvement with bystander CPR through legislation. CPR is required in schools between the grades of 7 and 12. We've done some legislation around AED placement. There's also a program through the Minnesota High School League for after-school emergency action response. And then, of course, the Heart Safe Community designation is another way that you can get local grassroots effort around cardiac arrest improvement. Next slide. So just to kind of summarize what we've talked about, we know that this project is going to be an opportunity to solve AED issues within law enforcement. We have several years to work with them and help them. This is really an opportunity with these new updated AEDs to not only give feedback, but also, the hesitation to use a device when there may be a cost. And they know EMS is right behind them. Now the electrodes being free, they're going to try them on everybody, which is fine. Even if it does not deliver a shock or the person doesn't need it, they know they're going to be getting another set of electrodes. And so this is a great opportunity through this funder to be able to provide this for law enforcement. Next slide. And just before I go, with Jim bringing up the story, that's a great story by Fairview with the patient on ECMO. We actually have already had a situation where we had a reuse AED go into a fire department the exact same day they got it. They used it on a patient who was eventually transported and placed on ECMO. And so really seeing all these new opportunities around cardiac arrest and resuscitation kind of all come into play. So I would open it up if there's any questions. This is a link to our website. You can see our team here or follow us on social media. We're always trying to push out the stories similar to what Jim talked about. And thank you for your time today.
Wonderful. Thank you so much, Kim. I really appreciate it. I believe my colleague Mimi is going to drop the link in the chat for the survey. And if you're catching this on YouTube on the replay, please note that the link for the survey will be in the description box. And again, if you have any questions, please feel free to email us at health.state.mn.us, health.stroke@state.mn.us. And I know we're a little over time today, so I want to thank you everybody for joining us, and please join us next month.